Okay, John, tell me when you're ready to go.
We still have people coming in. We have, can't tell how many, but I'd say we've got about 60 people in right now.
Yeah.
Just remember when you come in to please mute yourselves. That'll be really helpful for the progression of our webinar today.
We're at 70 participants right now.
Okay, I think that we're going to get started, and as people trickle in, they can join at the time that works for them. So hello everyone, welcome to the webinar hosted by the Ontario SPOR Support Unit, or OSSU's Patient Partners Working Group on building capacity for patient-oriented research. For those unfamiliar, SPOR stands for the Strategy for Patient-Oriented Research. We will be recording today's webinar and saving the chat. I'm Lucy Langford, and I use she and her pronouns. I'm the vice chair of the Patient Partners Working Group, and I live with a chronic health condition. I will be moderating the discussion today with panelists Leblanc and Ambreen Sayani. Audience members, feel free to introduce yourselves in the chat, and if you're tweeting, please use the hashtag OSSUWebinar. I'd like to first start off with a land acknowledgement for the location that I am currently in. Recognizing that with a virtual webinar, we are all in different places, and I encourage you to explore and learn about the traditional lands where you're from. We acknowledge that OSSU is located on the land we now call Toronto, and that OSSU operates across Ontario, which is home to many diverse First Nations, Métis, and Inuit peoples from across Turtle Island. Toronto is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is covered by Treaty 13 with the Mississaugas of the Credit. We are deeply grateful to the generations of people, past and present, who have tended to this land and acknowledge the abiding wisdom of the Dish with One Spoon Treaty between the Anishinaabe, the Haudenosaunee, and to share and care for the land. As settlers, we are thankful for the opportunity and privilege to meet and work here, and we seek to move forward with humility, respect, gratitude, and meaningful relationship building. The Patient Partners Working Group is hosting this workshop to help with the increased demands to engage patient partners in research. Often researchers and people who would like to get involved find that there are no known entry points for this engagement, so researchers are sometimes turning to the same known patient partners. Especially this is true during COVID, at least we're finding. Consequently, we're not achieving diversity or equity, nor are we providing the opportunity for others to learn about deep patient engagement principles that allow for this engagement. Currently, efforts to support patient partners are limited, with no broad or systematic efforts by research institutions or research teams to support or train current patient partners. There are also no coordinated efforts to recruit, mentor, and support patient partners. The decentralized nature of the work means that patients are often left on their own to learn and are not compensated for their learning activities and are not guided by common principles of engagement. With saying this, you might wonder why there are no patient partners on the panel, and this was a deliberate decision that we made. There are many patient partners in the audience today who are experts, and we encourage your participation as an extension of our panel. We'll be using a program called Mentimeter after any speaks, and this will be used to gather audience feedback, and we'll give you more information about that when it's time to use it. There'll also be a question and answer period for both panelists after the second presentation by Ambreen. We'll now start with a poll to see what our audience looks like today. So John, if you could help me out with that, that'd be great.
So everyone should see the poll now. Oh, they are.
Yeah, John, I don't think we're seeing it.
So people are responding. So
Oh,
some
great.
people are seeing it.
Oh,
and,
cool.
And Zoom did say that if you had an old version of Zoom, you might not be able to see the poll. So I apologize for that. But we do have 70 responses so far.
I unfortunately cannot see it. So if you'd like to give an update for those of us who can't see, that'd be great.
If you'd like, I can end this question and then display the results.
Great.
So hopefully folks can see the results.
Okay, awesome. So with this, is there any more questions that we're asking?
Yeah, there should be 2 more questions. Maybe I need to turn it off. Okay. Oh, I'm sorry. All the answers were, oh, sorry. All the questions appeared at the same time. So I may only have showed the beginning of the question, of the first set of answers. If you'd like, I can summarize quickly what the results were. Okay, we do see first, I think most of you saw that, the majority of respondents were from Ontario, with a good showing from Atlantic Canada, Quebec, and as far away as British Columbia. We had 2 people from another country. We also asked what kind of hat you're wearing, who are you with respect to patient engagement. We seem to have all people who have some link to patient engagement right now. The majority of researchers, the majority of respondents are researchers. We have several support unit employees from across the country, and we have a lot of patient and caregivers that are participating today. The last question was, how would you rate your level of experience with patient partnership in research? And most of the people say that they have some experience with partnering in research. A small number have a lot of experience, and we have no pros on the line. That's it for the questions.
Great, thank you for summarizing that for us, John. Next, we're going to move to our first panelist, Annie Leblanc. So take it away.
Thank you. So let me share my screen. And I'm going to do this. Here goes. Now let me see. So do you see everything's fine? You're seeing my presentation well? Perfect. It's always a challenge with multiple screens. Good afternoon. Bonjour à tout le monde. Thank you for this invitation. I am very much looking forward to these virtual discussions with you all. So please don't hesitate to share thoughts and suggestions in the chat, in the Mentimeter, in both French or English. On pourra répondre en français aussi. Si les questions sont en français. I've been asked to talk a little bit about myself before moving on. I am a full professor in the Faculty of Medicine at Laval University, a researcher at the Time Research Center on Sustainable Health here in beautiful, snowy Quebec City. For the past 12 years or so, my work has been to, improve patient-centered care has emerged from and actually been conducted in partnership with patients, their loved ones, their care teams, first in the US at Mayo Clinic and now here at the TAM. Since my return in Canada, I have been so fortunate to join different patient-oriented research organizations, such as the SPOR Evidence Alliance and the SPOR units, and collaborate with amazing, dedicated individuals throughout Canada. Recently, with colleagues and collaborators across Canada, we were awarded and tasked with the establishment of the SPOR National Training Entity, which is dedicated to building capacity in patient-oriented research across Canada. I was asked by this working group of OSSU to share that vision is what and what's coming. Recognizing that this is a fairly new entity. So perhaps for me, it's about sharing a little bit of our visions and then hoping actually to hear from all of you in seeing how we're making sure that this entity meets your needs. So the entity above all, first and foremost, this national entity, and I'm going to call it the NTP for now. And hopefully that's the only abbreviation I'll be using to this talk, but above all, this entity is built upon the strengths and the success of all of the work that you have done and that the SPOR units and the networks has done. So it's building on the work, the lesson learned, some of the gaps that we've already talked about for years now, and all of these established partnerships. So thank you, and thank you. We're there to leverage, disseminate, and sustain what has been accomplished, and hopefully help support and further this capacity building through innovations, and hopefully grow this patient-oriented communities that we have here in Canada. So the NTE it was founded on those principles of shared collective expertise and experience. And it brings over 100 different Canadian experts. And please do know that when I'm talking about experts, it refers to patients, to health professionals, to loved ones, to citizens, to researchers. So for me, it's anyone who's dedicated to this work and that has spent a number of years making it happen. Across different, over 50 networks, organizations, and different research group. Our goal is really to act as a network of network and to be able to support the multiple needs and all those viewpoints already active in our Canadian landscape. So across all that, there's above all a few people that have been involved a little bit more since the beginning. So I do want to acknowledge our principal investigators and knowledge users that have been key in setting this up among all of other collaborators. You have on the screens our principal investigators, knowledge users, in blue, our patients partners, in gray, our trainee partners. We wanted to make sure as much as we involve patients and different knowledge user, it is a training platform. So for us, it was key to also have trainees across Canada that tell us about what is needed. And for us, a trainee is anyone who wants to learn, who's there to move forward this science. So our trainees are academics. They are also from the healthcare communities, are also patients. So hopefully it becomes about being a learners and not about which setting you come from or which type of knowledge users you are or as stakeholders. And I do want to say that we've been fortunate to have Alexandre Parent, who's just been nominated as our executive director, who will help us move forward with this initiative. So the objectives of this national training entity, and for those, again, please don't hesitate if you have French questions. I'm not going through that French part, but you do have where I offer the French version of what we're going through. So the objective of this entity is really to co-develop and first of all, maintain a central body of core capacity development and mentoring in Canada. And I'll talk a little bit more about what it means and where you could actually contribute and help us make this successful. We are tasked to cultivate and grow a community and active and engaged communities in patient-oriented research dedicated to capacity building to support and empower mentors and trainees. I look forward to hearing around that. It was mentioned earlier in the talk that it's actually one of the key struggle is how do we find mentors and how do we help build that capacity and how to find more patients to engage in this work. And we are also tasked with fostering new linkage and trying to expand this community. So how do we go beyond those that are currently involved, and how do we grow this to the larger group, a larger group possible? And also through all of our activities and all of different objectives, we do want to make sure that we incorporate Indigenous Western paradigms, and that everything that we do follows the principle of equity and diversity and inclusion, and again, in both French and English. So this national entity is actually built into 4 core functions as per CIHR's requirements, and the different activities will be set through these core. And this is where we're hoping, in thinking about these different activities, where do you see yourself? Where do you see that you could contribute? And I'll come back to these contributions in collaboration in a minute. So in thinking about this central body for training, so we are building this inventory where in a few months from now, you'll be able to find all of those different initiatives and training that are available in patient-oriented research, from patient engagement to more advanced methods for research. So we are working on this inventories. We are working in setting up also different stream and certification process to recognize the work that is being done and conducted, as well as fostering different experiential learning opportunities for all of our learners. With that core function too, building those communities of practice and really working toward how do we create these communities? How do we create activities, webinars, conferences that are tailored to the needs of our users, and particularly now with the pandemic over our head and being all virtual events? How will we make sense of that community? How do we further share this collective knowledge that we've built? So you see a few of our activities below, and hoping to grow these different activities. As per the core 3, one of the things that is key to what we're doing, and this is actually one of our priorities, we are working with with SPOR and the SPOR awardees that were announced a few months back. But we are also prioritizing the development of new awards and mentorships and fellowship programs, recognizing that there is a great need for these type of award, not necessarily, and not only for academic trainees, but really for patients, for their families, and for the healthcare workers that would like to know more, would like to be further engaged, but that lack opportunities. So trainees, stipends, and different kind of awards will be set up for these, and I'm happy to chat a little bit more further afterwards. And then again, through all of this, how do we bring forward the work that has been done? You've mentioned mentorship earlier. We do, as we work throughout developing this capacity, we do recognize the importance of developing good mentors as well. So how do we make sure that those that have that expertise and experience also get the support needed to help others? This is one of the key elements that you will see over the next 6 years. And then again, how do we build those linkage? How do we build that sustainability across all of our networks, all of our units? Here's some of the core. I'm just showing quickly this governance structure, but the key message here being that our patient partners and our trainees are involved throughout our governance structures. They are the ones that are leading our work. They are the ones that are telling us how and when to prioritize activities. And we do still have opportunities for collaboration. So please, if you're interested in joining some of our governance committees, if you're interested in collaborating in the developments or co-constructions of activities, or many are inventory as well, If you're interested in giving us your opinion around where we should head with our training, our scholarship, our awards, if you'd like to mentors and so on and so forth, we are there to, again, I think I've said it a lot, but it's really what we're there for. We really want to build these communities. We want to put forward the amazing work that you have all done throughout these past years. So please don't hesitate. You have my numbers and you have Alexandre's number as well. In the bottom, we are working towards setting up all of our presence in social media. Those who have this type of networking or organization knows it takes a few months to get up on the ground and running, but within a few months, our webpage should be up and running, and you'll be able to communicate through that. Meanwhile, don't hesitate to communicate through that. So that kind of gives you that overview. We are at the beginning. It's been only a few months that we've been up and running, so it is still the time to join up and collaborate, because nothing is set in stone yet. So we look forward to ideas, comments, and collaboration from your group. So there you go. Thank you.
Thank you. Are we going to gather some feedback using the Mentimeter now?
So I put the web address for Mentimeter into the chat. If folks would like to surf on over there, and the passcode there is the 8-digit number, and I will display the Mentimeter question now.
We're going to use this to gather some feedback, and it will kind of create a word cloud type of a thing. And so we really hope that you're able to kind of access that, and we will put it up on the screen.
So, so please do the first questions for those, if you're not able to see it. That first question pertains to that exactly building capacity. So how do we further build capacity for patients to engage and remain active in research? And, you know, in thinking about, and I'm loving what I'm seeing, because often we associate capacity with training, and I didn't mention, but it goes so much beyond training. It's about the support, it's about the financing, it's about the enabling of our system as well, to be able to support that work. So thank you for all your comments. I love seeing that word cloud being built. So.
Great. Yeah, this is really good communication, patient partner registry, really great, great suggestions, encouragement, educate about the benefits. That's a good one, probably from both sides, both on the researcher and patient partner side. John, is there the next question that we can go to? Here it is. Here's the next question. Why has it been challenging for you to engage diverse voices? We aren't seeing anything yet. Maybe this is a challenging one. Oh, wow. There you go. Some folks saying that it hasn't really been challenging, which is really great to hear. If you have any suggestions or experience, feel free to kind of type that into the chat for some best practices, time, knowledge gaps. Yep. And I think that the NTE is really going to help with that. Not meeting patient partners in their communities. Great. This is great feedback. Thank you, everyone. Yeah. A lack of shared understanding about the research process. Great, thank you. Is there one more question? Nope. Okay, that's all. Thank you so much, Annie. I really appreciate it. And next, we're going to move to our next speaker, Ambreen. So take it away, Ambreen.
Thank you so much. I'm just going to put up my slides. And we should be good to go from there. Okay, so thank you for having me here today. I think this is such an incredible opportunity to have a dialogue about something which we struggle with in terms of, conversations that we have, trying to make our work more meaningful and basically get better outcomes from the work that we do. So I was asked to introduce myself a little bit, and I will start by doing that, but then I will touch upon the idea of engaging diverse voices. What does this really mean? What are the challenges that some of us have already identified in the word cloud, some opportunities in the way forward? So much like anyone involved in the patient engagement space, I do have a story to tell as well. And currently I am a SPOR-funded postdoctoral fellow at Women's College Hospital. But my journey to this point is rather convoluted. So I started off training in medicine. I did my residency in surgical oncology. I then went on to do a fellowship in research oncology and came back to clinical practice thinking I was armed with everything that I needed to do really good patient care. But then when you sit and have conversations with people, you realize that you're not always hitting the mark there correctly. And there are other things that need to be done and perhaps need to be done at a more strategic level. So that was a fork in the road for me. And that's when I shifted more into strategy, policy making. And that was another longer journey and another story for another day. The bottom line is I did my PhD in health policy and equity. And those theoretical concepts combined with my own clinical background and training have kind of shifted the way I see these spaces in a very profound way. I think the idea of talking here today is just to share some of the lessons that I've learned along the way. I'm not an expert. I don't know everything. I'm just going to talk to you about what I have learned, and then we can open the dialogue up to what else can we do to do this better. So I think the idea, the bottom line is, well, who are we engaging with and whose voices are missing? And if I would dare to say who is actually not on this call today, right? Who are those people that couldn't be here? Because we all tend to be familiar with the kind of people that are here, but who is systematically excluded from this participation? And why does that happen? And what can we really do about it? And I think the go-to strategy when we start to think about that is, okay, so, there's this priority populations list, and we have a bucket list of identities that tell us who is living on the margins of our society, and therefore they must be the ones who are most excluded from our work, and therefore we must try and engage with these identities. And I would say using this list, it can be quite harmful for a couple of reasons. It labels people, it silos people, it buckets people, and it can otherize, meaning me versus you. And how do we actually engage in a more collective dialogue? I do like this picture because all of us have different elements of our identity that come together and form an intersectional lived experience. But what I do want to say from this diversity jigsaw is to shift you to thinking about this as an intersectionality wheel. Who we are, the place we occupy in society, how that has been shaped by our access to resources, whether it's wealth, whether it's social capital, whether it's cultural capital, all of those resources influence who we are, what we can do, what spaces we have access to, and what spaces are by design exclusionary to us. And I think I can't go further without, talking about the pandemic. We have seen how neighborhoods that have a higher proportion of racialized minorities, lower income populations, they've been disproportionately affected. Their voices continue to be left off decision-making tables. We're 2 years plus in, and we still see that some of the policies that come out, you got to be kidding me, right? I mean, what were people thinking? And what were we thinking in terms of who would benefit from those policies to begin with? So I want to take us through this. And I know we always say equity, diversity, inclusion, but I always like to put it in this sequence: diversity, inclusion, and then equity. Because diversity is a mix of a variety of identities and perspectives that are included in a space. Inclusion, however, is an environment where people are treated fairly. They feel welcome, they're respected. Equity, on the other hand, is an outcome where people aren't disadvantaged because of who they are. So therefore, you can have diversity, but you can't have inclusion without diversity. And you can certainly not reach a state of equity without first having been diverse and inclusive. So this brings me to where are we currently at with patient engagement. And I think this is by far the most common way we go about things, and it's worked really well. I think the work that's come out of patient-oriented research is very profound, very insightful. But just in terms of talking about diversity, inclusion, and equity, that's where I'm going to frame this from. Let's take a look at our infrastructure and our funding models, which are project-based, right? They are tight deadline-driven. We have milestones to reach. The policies in which these projects are hosted, the institutions, they can have exclusionary policies in terms of who we can engage with, how we can pay them, and how we can interact. When we move to the study space, the resources are usually so limited in terms of human capital, material capital. How many funds do we even have to partner appropriately? The deliverables are so tight. We all know we're running on tight grant deadlines. And the processes, therefore, that come out can reinforce those structures of exclusion. When I shift to people, I'm talking not just about the researchers or patient engagement folks that are in this space, but also patient partners. I think together we are a collective of people that form the study group. And I think, quite inherently, as this work has evolved, the focus has not been on social justice. And there is a lack of deep community relationships, as well as a lack of experience on how to engage in conversations that are authentic and meaningful with diverse communities. So this is what I like to call the cookie cutter model of patient engagement, because this is the cookie that we take and we try to template all of our patient engagement research projects with. But if we look at Maslow's law of the hammer, it's if you have all you have is a hammer, everything looks like a nail. And therefore, if this cookie cutter is all we have, everything in patient engagement looks like a nail. And I want to quickly take us through some commonly used terms here, because it's hard to go on without touching upon them. Hard to reach, invisible, and seldom heard. Hard to reach is used to describe individuals who are difficult to contact or engage for a particular purpose. They are hard to reach because projects have tight timelines. We have limited funds. We have exclusionary institutional practices. They're not hard to reach in themselves. Our practices make them hard to reach. What about invisible? These are groups of people that can't be seen by researchers, policymakers, and service providers. So we call them invisible populations. But they're invisible because we're sitting in our ivory towers that have been structured and socialized from the lens of a privileged, white, cis-bodied, abled man. And therefore, when we look out with those same socialized perspectives, we are unable to embed ourselves with the lens of community. And what about seldom heard? Groups of people are underrepresented at decision-making tables. Our decision-making tables live in institutions. They are structured and constructed by institutions. Very often, there are one or two patient partners on those tables. The power dynamics are so strongly influenced by the institution that people who have experienced trauma in institutions don't want to go anywhere near those tables just because of where they are. So we need new tools for this toolbox, right? We need to add some more things here so we can look at things beyond what we've traditionally seen. And this is how I would like to structure the cookie cutter, right? So infrastructure needs to exist right at the bottom. The funding levers that allow this work to happen, a culture of change within organizations so that the institution is tied together in terms of How is legal working with finance? How is finance working with ethics? How is ethics working with admin to support this kind of engagement that requires us to change the written policies that we currently have? Then come the people. We need to learn to think with an equity lens. That means put equity first before we do anything else. Do no harm. And by that, I mean explicitly not using words or language that otherize, that stigmatize, that are judgmental, that stereotype. And then build networks of trust. And I'm going to talk about that a bit later. When you have built up that way, you have a study that can be designed to be accessible. And I mean, not just physical participation, but digital participation. You can foster co-learning activities. So I learn from you, you learn from me. We both know some things, we both don't know anything, but together we can learn a lot together. Clear communication and adequate resources to be agile enough to respond to the needs of the study and to the needs of the patient partners on the table. And I guess I'd like to say that this is already happening, right? So when we talk about the SPOR awardees, I am a SPOR awardee, and the funding lever that I have is this 6-year career development award into which capacity building is inherently built. So I have the funding and the time to make the space to do this work. I also work in an institution, Women's College, where their legal finance admin has been amazing. We have rewritten digital device policies. We have rewritten how patient partners should be compensated, but the institution has moved with me in terms of where I need them to be. So this work is already happening. It's not too far. It's just a shift, and we can do this. I did want to touch a little bit on the networks of trust, because this work cannot happen well unless we are committed to building and nurturing long-term relationships. Those relationships happen only when we put trust at the core of it. And I think any other work can be left out if it hinders upon the trust and the relationship. So the people working on a project, acknowledge personal and institutional histories, right? Before you even try to engage. Understand the historical context of the research that you're getting started on. Be present in the community, listen to the community members, acknowledge everyone's expertise, and be upfront about expectations and limitations. Why are you here? What's in it for you? What's in it for anybody else? And be totally authentic. And once the project has started, create clear communication plans, revisit those plans, and match your words with action. That is so very important. So a couple of notes. I think if I were to take a jot pad and write notes for myself, I would say when I move forward with this work, I need to begin first and foremost by unpacking my own privilege. I need to meet people where they are and not expect them to come to where I am. I need to meet people when they want to meet, on the terms at which they want to meet. I need to be authentic. I need to invest in those relationships. And I think one point to make here is that it's never too late to start a relationship, and it's never too late to build a broken one, right? So start now and go for it. Just be in places and engage in conversations just to get to know people. It doesn't have to be for an outcome. You're just there because you want to listen and you want to be around people, and be ready in that moment to engage in uncomfortable conversations and have a growth mindset. I think I just want to conclude with this last note for the jot pad, which is notes for the study team. Diversity work is social justice work. You really can't get into this diversity, inclusion, equity space unless you have the framing of social justice. A lack of attention to diversity can perpetuate social injustices. And I think that is the other side of the coin. So whereas all work may not be driven by a social justice framework, a failure to do so can perpetuate health inequities. We need to be conscious of that. And therefore, everyone in this space needs to build the skill sets required to understand and attend to health inequities. And I agree, it's not possible for everybody to get a whole toolbox of those skills, right? But you can definitely onboard members onto your team that do understand, the theoretical aspects, the practical aspects, that can review the study structure, that can advise on what needs to happen to make this study more inclusive and more equitable. And I think another really important point here is that it's not always about what your study can do, but also what your study cannot do. Therefore, if you know that certain aspects of diversity, inclusion, and equity are not being addressed by your work, please do say it as a limitation of your work, because the more of us that say this, we make this space visible. If it's unheard, if it's unsaid, it is invisible. If it's a limitation, please come out and say it. That is just as important. And create safe spaces for patient engagement and shift the power back to communities. Make sure everything is as accessible as it can be. Communicate clearly, have a compensation plan, and keep revisiting things. And that's all I'd like to say. Thank you for letting me share my reflections.
Thank you so much, Ambreen. That was wonderful. I resonated with so much of what you said. Really hard-hitting talking points, like your 7 suggestions. I love those. And kind of the rethinking the equity, diversity, and inclusion to be diversity, inclusion, and equity. So thank you so much. We're going to take some questions. So please put them in the chat. We will also take verbal questions by using the raise hand function. I see that some of the questions that were asked previously were answered by Annie, and I'm not sure, did you get to the question, Annie, about how do individuals participate and collaborate if they're not affiliated with a specific group?
No, I didn't get
All right, well,
to that one.
We'll kick it off, and that can be our first question.
I was listening to Ambreen. Thank you so much for that, Ambreen. So interesting and meaningful. Yeah. So if you're not involved with those SPOR units or networks, please do reach out to Alexandre and I for now. And Alexandre pointed out that I think I missed an S somewhere in his email on the presentations, but you do have the right one in the chat. Please do reach out to us. This is what we want. We want to grow our communities. We want to learn from others are doing across Canada, elsewhere. And, people were engaging, people were doing this type of work prior to the whole SPOR arrival and so on. So we want to hear from you. Please do so, and then we'll work to either see how you can contribute to any of our programs or initiative. But again, I will say that I see myself as matchmaker, but hopefully we'll be able to help you link to the organization that could perhaps be of best interest to you. Again, it's a network of networks. So hopefully we can then link to all of these different patient engagement groups or organizations that could help with some of your interests and work. So.
Thank you. I see a contribution in the chat that says that if they would add anything, they would work with patient partners to determine patient priorities and research first. That's a great one. And there's some really fabulous methodologies out there to do just that, such as like the James Lind Alliance for one example. Any other questions that folks have? We have 15 minutes to answer your questions, and I know that our panelists are raring to go. Here's one. Will the NTE have any funding for specific patient-oriented research POR projects?
This is a good question. Actually, we will be working on different type of stipends, and I don't want to say funding, because people then think there's hundreds of thousands of dollars, but we will be working to establish stipend, particularly for patients, so that they can move forward with their work. And perhaps Ambreen, you have some thoughts on that, but where we want to make sure, because we'll say, many times we'll say, let's put in stipends, or let's put in awards for EDI, for patients to engage. But it goes beyond, it goes beyond those awards, because you need to build that capacity. You need to make sure that they can travel, that they have the support, that they have the mentorship to be able to even use that stipend. So I want to say that we are aware, we do want to put some initiatives forward, probably not until next year though, because we want to take time to consult with patients, to consult with our EDI community to see how do we make this a reality. So how do we ensure that in putting forward stipend and awards, we also put the support so that people that are getting these have everything in hand to be successful. So we want to make sure that that is there. So I don't know, Ambreen, how you see this and what is kind of needed in terms of support to make those award and stipend a reality.
I think from a diversity perspective, it's so important to have that network of trusted relations. And I mean, not just within community, but within health systems as well. So it is who you tap on the shoulder that you can trust to be a safe space. And I know that's a very qualitative thing to say and cannot necessarily be measured, although there are surveys to measure trust out there. But this is inherently one relationship to another and embedding that work. So how do you fund relationships? Is it a stipend? I think it's more than that. I think it's funding the people who are actually able to build out that network and nurture that network and bring other people along with the capacity and skills to further that trust. I think I see it perhaps in a bit of a different way of investing in the in those people that are able to nurture those networks.
And perhaps, thank you. And perhaps to add to, I think it was Sandra and Joanne who were talking about, having patient partners to determine priorities in research, and we totally agree. And perhaps just to keep in mind that for us, for this NTE is about determining priorities for patients that want to engage in research. So I think that distinction is clear, but I do want to say, so it's about what will help you build that capacity and what will lead you to engage, not as much as what are some of the research questions that we should prioritize. So just to point this out. So for us, it's about finding those ways and support and initiatives that can be, and we are working with both our patient partner group to identify those priorities, but also with our trainees. And again, remember that our trainees come from in all of our different type of stakeholders to identify this type of activities. So we have two groups actually helping us set this type of priorities and capacity building.
Wonderful, thank you. The next question that we have is for Ambreen. How are we making progress in EDI and how do you know?
In terms of metrics, I don't have any numbers at the top of my head. I can speak from personal experience. The fact that I got this funding, the fact that we're having this conversation, the fact that it's top of mind for a lot of people who I speak to. When things become a priority and money is put behind it, I think we're moving up the chain. I think that's all I can say at this point. I don't have any statistics to say that we've moved a needle in terms of, I would say DIE, but that doesn't really sound like a very good acronym, but EDI does sound better. Yeah, so I can't say that in a quantitative way, but I can just speak from personal experience that we are having these conversations more and more and money's being put behind it.
Is there any way that folks who are wanting to do it, how they might be able to measure whether they're doing it correctly or moving the needle? Do you have any feedback on that?
I think some of the key priorities in the work that I'm doing is to be able to share the process journey, because very often how do we do this kind of community and patient engagement work is missing from the outcome metrics that we see, as well as the impact measures that we currently have. Therefore, trying to be very explicit in terms of what were the processes that I did to get where I am, so that when the outcomes of my work are published, we can kind of begin to draw those links between process and outcome, and then see how that we reach those levels of impact. I think those are really important parts of our current journey that I think, we need to, if we're looking in terms of solid research, we need to wait a bit for it. But I'm happy to share more about the work that patient partners and I are doing in EMPACT, Equity Mobilizing Partnerships in Community, and also a lung study group where we have a patient partner working group, which is completely diverse. So I'm happy to share those models and how we did that. But for the process, outcome, and impact measures is work that's currently happening.
Thank you.
And Lucy, if you allow me to just point out, Ambreen is one of 23, and I'm hoping my count is good, but one of 23 fellows that have been awarded this Transition to Leadership Award from SPOR and CIHR. And I've met with most, if not all of them, over the past few months. They are an amazing group. They are the future of patient-oriented research. And I'm saying that because the majority of those that I've met are focusing on any aspects of EDI or Indigenous research. So I would recommend for you to reach out to see who they are. We'll see. We're working with CIHR to make the for you to be able to know who they are and what they're doing in terms of work, and we'll be sharing more of that later. But many of them have that focus as Ambreen has, and they are doing phenomenal work, and they're always looking out for collaborations, contributions, and see what else they could do to improve what is currently being done. So please do reach out to them and those that you see a specific interest in what you do in your own work.
I love that we're going to be having examples of how to do this. And so it'll, like Ambreen said, it'll be a real impact behind the words, and that will be serve as a good example for others who want to engage in this work as well. Our next question is that somebody mentioned a patient partner registry. Are there any thoughts on this? And how would you recommend that we meet potential patients where they are? I think that could be a question for both.
Ambreen, do you wanna start?
I can take the where do you meet patients where they are, and I have to admit the pandemic really blew us off course. But traditionally, I can speak from my personal experience where I've tried to meet members of community is at the library, at the community center, at a community kitchen, at a social service center. That's where you want to be, and you just want to be in those spaces and be a person who's available to and ready to talk about anything that somebody else wants to talk about. So I think that's where you meet people where they are. Just a small piece to that, to add on to that, is the patient partner groups that I have been able to put together during the pandemic were built off those relationships, right? I couldn't be physically in those spaces, but because I did have those relationships prior, I could tap them on the shoulder and literally go from that one person to another and build out these communities that currently guide two key parts of the work that I do. So go where people are, go to places that make you uncomfortable, really, places where you haven't been, that test and push your boundaries.
Thank you, Ambreen, which and I could perhaps say, which bring to my own personal, and again, I'm not an expert in patient engagement. I engage patients in my research, and I do different work, but I'm always concerned when we talk about registries, because from the work around building patient registries, they are often the patients the participants that are mostly involved, and we see discrepancies, and we see underserved and underrepresented population through these different registries. So my concern is by building these registries, we're not meeting the people that needs to be met. We're not engaging the people that needs to be engaged. So I think we do need a way by which we are enabling people and finding ways by which they can collaborate and say that they are interested, and meet them where, exactly as Ambreen say, where they are at and trying to support their capacity. I've seen too often, patients been involved in research, but they have no computer, no Wi-Fi, they struggle. So, in enabling and meeting them where they are, it's not about that physical space, but it's also about where they are at in terms of technology access and what they need to make this a reality. So I do think that we do need to keep a way to engage and help build their own capacity so that they're not only come in, but they do remain and they do share their experience with others. But I would be careful of those registries. But I know there are so many others that have more expertise and experience, and I'd love for them, for you to share your thoughts on that on the chat. But those are my personal thoughts.
That's great. Thank you so much. Due to time, because we're going to be ending at 1, we're going to wrap up. Thank you everybody for your questions and your participation. I really, really appreciate it. I think that we heard some excellent points, Annie, from kind of a national perspective, what we can look forward to, lots of opportunities to collaborate. You've provided your contact information. So folks with ideas about training patient partners as well, please get in touch with them because we're very privileged to be getting in on the ground level with that. So that's great. Thank you. And Ambreen, you had some great practical suggestions, a reframe of how we think about EDI to be diversity, inclusion, and equity, because without the prior, you can't really achieve equity. And I like what you said about getting away from this cookie cutter patient engagement model. And you provided some great suggestions of where to meet patients where they're at, people where they're at, soup kitchens, et cetera. I think that you also really made great points about kind of the ivory tower of research, and to think about how systematically kind of we aren't set up to consider others' perspectives, and to really acknowledge when those are missing, and that is a great level of awareness that researchers can have to state that they are missing certain things. I would very much like to thank everybody for their attendance. I would like to thank specifically the webinar group that's led by the Patient Partners Working Group and the Ontario SPOR Support Unit OSSU Coordinating Center for helping support all of this. Contact information, we may be following up with participants. This recording will be available on our website, and I'd like to thank you all for attending, and you'll be able to make your next meeting with maybe a coffee break for you. So take care, everyone.